vascular interventionalists have reached out to me about different concerns that they have, and we thought that we put together a phenomenal group of panel today that sort of can talk us through some of the issues at hand. One is, of course, whether atherectomy should be considered in patients with PAD, and second, of course, is whether claudication patients should be treated, because we certainly have some intersocietal politics, which has led to some confusion in our patients' mind after reading some of the articles in the news, and also has affected the payers. I think that many of us who are directly involved in the PAD business and knows it very well. Many of these PAD procedures are requiring pre-authorization. So I think that it's time to reset the clock and start getting into the details of some of these criticisms. So we have an unbelievable group of faculty members today. We have Dr. Eric Systemski, who is our first speaker, who is the director of vascular intervention at Cardiovascular Institute at Beth Israel Deaconess Medical Center. He's also the section head of interventional cardiology and vascular research there, and he has published extensively in the PAD area. He's going to speak to us about why atherectomy is justified in 2024 in patients with PAD. And I'm very curious to hear what Eric's take on it is. I've been doing atherectomy since I started in 1998 when laser was the only option. And the atherectomy is sort of the default procedure for majority of our PAD patients. So welcome, Eric, and I turn it over to you now.
Great, thank you, Raj, and thank you everyone for taking time this Saturday morning to join us and have this wonderful discussion. And I took the liberty of, just switching around the title of my talk a little bit, and because one question I get a lot of, and that comes up frequently when we talk about atherectomy, is also place of service, and whether you're a hospital-based practitioner or an ambulatory practitioner or both. And many of us are both, especially on the cardiology side. But I want to make sure we cover both topics as they kind of intertwine through this journey of atherectomy. I use the Sahil's comment about being a card-carrying interventional cardiologist. I do these peripheral procedures, I do coronary procedures, and it's always interesting to reflect on the differences between the two, because we have terms like rota regret, and I like to say we have IVUS regret. We have times where we should have imaged, or we should have rotated on the coronary side. We don't really talk about overuse on atherectomy. We don't talk about overuse on imaging. We talk about underuse. And so it's always interesting to flip that into the peripheral space where everything's about overuse and inappropriate use, and for very similar tools that we're doing on the coronary side. So hopefully I can just lend a little bit of evidence behind where practices are right now in 2024, including, again, the site of service, as well as the tools that we use to care for our patients. These are my disclosures. So, as Raj nicely introduced to us, we had quite a year last year. The year started with steak dinner, sales reps, and risky procedures by ProPublica. We thought that was an interesting article and made some headway, and that was then followed by the Wild West of outpatient vascular care. And then we had our big article on the cover of the New York Times. They lost their legs, doctors and healthcare giants profited. So, again, this isn't the type of exposure any of us want, any of our practices. I think everybody here wakes up with the intent to only do good for our patients. We spent a lot of time getting to this point in our careers, and so it's quite a disappointment to see these type of articles show up. And it's really a disservice to our patients who are confused, who are scared. I remember my partner, who's a non-invasive cardiologist, called me and said, that New York Times article is like, I don't understand why these vascular surgeons are hurting all these people. And I'm like, first off, no one's hurting anybody. And second off, many of these weren't vascular surgeons they were calling out. It's quite the opposite. And so there's just a lot of confusion. And so I hope to spend the next 15, 20 minutes just to talk a little bit about some of the data that we generated, in support of atherectomy as well as outpatient care, and maybe a few pearls about where we need to go as a field. I just want to end on this one. This came out just at the end of the year. And these, the scary part of these stories is that they just become more targeted. You know, it went from a field, and then it started to go to companies, and then it started to go to individuals. And, you know, I think as a fear of mine is the role of the lay press in these battles and what's underlying the lay press when they do generate these articles. And so, you know, these are good warnings for all of us. So how did we get here? You know, I think one thing that gets called out a lot across the, you know, cardiovascular space is how big a market peripheral artery disease really is. And, you know, we've spent, as many of us are cardiologists, but a lot of time over the last couple of decades really creating the coronary space and then the structural space. But, you know, this is a $10+ billion industry projected to growing faster than coronary intervention right now. And so because of that, there is a lot of attention on peripheral vascular care right now. And again, that tension is not always good. Some's good. There's investment, there's innovation. Companies are excited to bring out the next device. We're going to make peripheral vascular intervention durable like we've made coronary. This is all in our future. But, you know, there's also a lot of unnecessary attention just by the reimbursement side of this and the amount of revenue that's going into peripheral vascular care. And as you all know, I don't need to inform an informed audience, but, you know, PAD is not a declining condition. You know, we see less and less, you know, acute coronary syndromes, but we see more and more peripheral artery disease. And if you think about this on the worldwide level, more than 230 million patients with peripheral artery disease. This continues to double and triple over the years. And we know now that more than 12.5 million US adults have peripheral artery disease. This is really a non-discriminatory condition. We see patients, in particular in their 5th and 6th decades, have higher and more frequent in prevalence, and that is no different in high-income countries between men and women. So this affects all of our patients, everyone we care about, and it's increasing. And again, as I just mentioned, there's much funding, money going into this, including in the healthcare systems for hospitalizations, procedures, surgeries, and whatnot. You know, but the one thing that we don't always agree upon is how do we treat the same patient? And I know we'll talk a little bit about claudication in the second part of this session this morning. This is a study that was done with an international group. You can see all the different countries on the y-axis here represented. I circled the data from the US. And this is looking at the proportion of patients who underwent a peripheral vascular intervention who had intermittent claudication. And you can see in Russia at the top, the majority of their patients were claudicants. In Italy, they're much more focused on the CLI, CLTI patients, and we're kind of in between. About 40% of our patients are intermittent claudicants. But, you know, it just shows you even on a national level that we all have different, really, you know, beliefs about the role of peripheral vascular intervention with patients who have stable disease. I think we're more on the same page about people who have emergency unstable disease, as I like to call it, CLI. But you know, again, we don't all agree about how we approach these patients. And I think it's also important for us to remember that this is one condition, like many of our cardiovascular conditions, that it's not a one specialty program. And so, you know, this came out a lot coming out of the BEST CLI and some of the other clinical trials that were heavily represented by one specialty. But if you look at the breakdown in the US, this is only for Medicare patients and presenting with the condition critical limb ischemia. You can see about more than 40% of procedures are performed by non-surgical specialties. And so it's just important for us to remember that this is really a shared condition that really requires us to be able to move between the taxonomy lines and reach out to each other for collaborative care. The one last thing before I get into atherectomy is just how vulnerable this patient population is with peripheral artery disease. And if you look at in the blue, the dark blue here, these are people who underwent an intervention for peripheral artery disease. And the light shaded blue is all patients, and this is from the Medicare data set. And you can see that people who are undergoing peripheral vascular interventions tend to be more minority race, live in lower socioeconomic regions. And we use a marker of income of dual Medicare and Medicaid. So if you're on Medicaid and Medicare, you're more likely to be low income. And so this really creates also an extra layer of sensitivity, is that these patients are vulnerable. We all know this. Their health literacy is poor. Their resources are incomplete and frequent. That many of them are working and dependent on their jobs. So, this is a really vulnerable population we need to be particularly sensitive about. So, we're going to talk about atherectomy, but I wanted to start with the shift of peripheral vascular care from the hospital-based centers to privately owned ambulatory surgical centers, as well as office-based labs. And this is really triggered by a change by CMS in 2008 that did a deep, exploration of the cost savings for moving these procedures outside of the hospital. Interesting enough, there was not a ton of investment in determining the safety of these procedures. It was part of this, but this was really also looked at as a important part for the healthcare system, that this condition's growing. If we can do this in a more cost-effective way outside of hospital centers, then that could be to the benefit of everyone. And, we've seen that since this rule came out, that there has been a real investment in maturing the outpatient pathway for peripheral vascular care. As many of you know, that's also now in place for coronary intervention. And clearly Medicare is supportive of this shift, because this is helping the healthcare economics, which are particularly sensitive, as you know, and especially after COVID. But, what happened after peripheral vascular care was approved for the outpatient center? This is a really nice figure from Skylar Jones and group out of Duke. And they showed in orange here is inpatient care, purple's outpatient, and blue's office. Is that really procedures followed that ruling. And you can see that the number of procedures in the ambulatory setting started to really increase. And the effect that we wanted was to reduce the hospital burden. Those inpatient procedures became quite more infrequent. If you look now, there's a large share of peripheral vascular interventions being performed in the outpatient setting. This is probably our largest or second largest site of service right now. Inpatient is by far and away third, as we all know. So it's important just to think about the impact of that on peripheral vascular care. So, everything gets confused. And so outpatient care grows. We start offering patients a more easy access to centers to get their peripheral vascular care. These centers are sprouting up in areas that don't have high quality tertiary care hospitals, and they're serving a need. And then we get confused because there's atherectomy. Now, everybody here is familiar with atherectomy. In the coronary space, as you know, we really have three atherectomy kind of bins. We have laser, we have orbital, we have rota. In the peripheral, we have a much more diverse array of devices, and I'm highlighting some of them here on the left. And this includes devices, in particular directional atherectomy, which is still a very frequently used device in the peripheral vascular space. Atherectomies come on the market, and I look at it as you can't do your job without the right tools. The atherectomy devices are there to help us get through our procedure when we think that we can't get through it with just balloons and stents. But the one challenge in the peripheral vascular space is these devices are part of a streamlined pathway through the FDA called the 510(k) pathway, which allowed them to come to market with minimal evidence. There's prospective single-arm evidence, but not the same rigor of evidence that we would see in the cardiovascular and coronary space. And I just highlight in this table that there's not zero, but few comparative studies of different atherectomy devices or versus standard of care like balloon angioplasty. So again, this is where all muddies the field of we've got a growing space, high prevalence, moving into private clinics. Reimbursement is part of keeping the lights on for any type of business, and then atherectomy comes, and these tools are important for doing our jobs well, but unfortunately, they're not having the same demand for evidence coming to market. And as you can imagine, and as you've heard, and as I highlighted in that article, atherectomy use has grown. And you can see that with PVI growth over the last 10 years, atherectomy has grown a little bit more disproportionately than the whole PVI space. And also one thing that's come out of this and why I kind of changed the title of this talk a little bit is atherectomy has been more frequently used in outpatient centers than hospital-based centers. And so this is giving the fodder to all the naysayers out there and all those who are looking to curtail interventional cardiologists and others' outpatient role in the peripheral vascular space as a means of pointing fingers and saying inappropriate use. This is one article that came out in JACC Interventions in 2021, and they looked at very similar data set that I spent a lot of time with, which is Medicare. And again, they were looking at how often and how varied the use of atherectomy is during peripheral vascular interventions. And they highlight the risks of needing a atherectomy device, which is, as per their article, really dependent on the site of service. And again, I'm not showing you anything new here, but I'm just showing you the attention these articles are unnecessarily bringing both to a device that we use, as well as a site of service that has become a very important part of peripheral vascular care. You can see in the middle of the this figure here, 53.8% of peripheral vascular interventions for the FEMPOP were done with atherectomy. 90% of reimbursement was due to atherectomy-related peripheral vascular reimbursement. So again, this is it's not, you know, unexpected that this gets attention. Again, this is business. This is how we do our job, but these are the articles being published. So, you know, why is atherectomy being used so frequently? What will the naysayers, what will people say for the inappropriate use? Is that they drive costs up. And you can see here, this is very early data, but if you perform peripheral vascular intervention in an office-based center, yes, the use of atherectomy is tied to more reimbursement. And that's been the big question about the appropriate use of this device is it being done for a reimbursement, measure? Again, I'm not here to opine. I use atherectomy devices. We'll have a discussion about this, but these are what people are coming to the table with in terms of why the inappropriate care is occurring. One question that comes up a lot that I find quite interesting is atherectomy use tied to a specialty? You know, and again, I think unfortunately, there's been a lot of divide in the field across vascular specialties. And it's unnecessary distraction for a space that just needs high volume, high quality, well-trained physicians. But, you know, if you look at the actual data, this is from a vascular surgeon back in JVS in 2017. The dark black is vascular surgery and the darker gray is cardiology. And when you look at atherectomy use, you know, it's pretty proportional between any specialty. So when we think this device is tied to a specialty, I think that is probably the wrong way to think about this. I think this is tied to a patient and a procedure. Now, we did an examination of this a couple years ago in terms of the interaction between atherectomy and outpatient care. And, you know, it was really important at this time as we were coming off the paclitaxel debate. There was a lot of still questions about appropriate use. There was, again, some of these divides forming again across specialties. And so we looked at where patients were getting their procedures and how outcomes varied across the procedure. And if you look at office-based lab procedures, so OBLs and ASCs, they're going to be the middle column, and I'll walk you through these tables in a moment. On the right is anybody doing a hospital-based procedure, whether it's a same-day outpatient procedure or a hospital-owned outpatient center. We excluded here inpatient procedures because in the current year, inpatient procedures look quite different. Patients look quite different. But if you look at the patients based on where they're being treated, again, we see what we've seen before, that atherectomy is more frequently used in an office-based lab, but it's not used in a hospital center. So look on the right here, about 36% of hospital-based procedures still use atherectomy. That number is higher in the outpatient center. Again, these are Medicare patients. If you look at the patients being treated, more minority patients are treated at office-based centers. And if you look again at these socioeconomic factors, patients who are lower income, again, we define that by being dually enrolled in Medicaid and Medicare, or living in poorer regions, and that's what this area deprivation index is, are more likely treated at office-based labs. So there's definitely an access part for office-based centers that is not spoken enough about that was coming out in these data. And I think that that's important because we can't get everybody to hospital systems. We learned that from COVID. We know that people don't want to come back to busy cities just to go to a hospital for a procedure that could be done locally. And so this is really nice demonstration of that in these data. The big, again, contingency on there is that amputation and the likelihood of getting an amputation is really tied also to where you live. And this is a really important map by Phil Goodney, Chief of Vascular Surgery at Dartmouth now, looking at the variation of your risk of amputation and your revascularization approach prior to amputation. And so if you look right in this region here, this is a region that I think many people on this call might be represented in. these patients are more likely to undergo a major amputation with no angiogram done beforehand or no attempt at revascularization. So all of the heat maps, all the hotspots for amputation are also the same hotspots are patients who are going straight from wound to amputation with no attempt at revascularization. And another really important map here is a profile of vascular surgeons in the US currently that came out in JVS just in the last year or so. And in this article, it was also clear that a vast majority of the US does not have a trained vascular surgeon. Vascular surgeons, when they do practice, tend to be more in concentrated areas and big hospital centers. So again, we have to democratize the idea here. And again, about where we're practicing, office-based centers, the tools we're using, and the type of practitioners that are needed, because we just don't have the workforce for any one specialty to own this condition. So we just need to move beyond that conversation. And I just want to highlight again that we're not really doing a great job for our patients. Again, we did this profile again, it came out just earlier this year, that 46% of patients in this article had an above the knee amputation, and 63% of them received no revascularization before amputation. I mean, that is just quite remarkable. And again, if you look at the patients who are undergoing this type of care, they're really the low-income patients getting care at a safety net hospital, and they just don't have access to the procedures and the specialists and the technology that they need. So again, this is really a call for the entire field that we can do better, and we are these patients more. So let's go back to outpatient vascular procedures and atherectomy. So our outpatient vascular procedures, where atherectomy tends to be more utilized, safe. That was the other part of the profile we did on this, published in Circulation just last year. And in these two survival curves, if you look on the left, this is our amputation-free survival, freedom from major amputation or death. On the right, it's just amputation. And in green is the office-based practitioner location, and then red is a hospital base. Now, many people practice in between both these centers, as I'm sure everybody here knows, but if you are brought to an outpatient lab, you actually had fairly similar, if not slightly improved, amputation-free survival. And this is adjusted for all differences in characteristics. Now, again, do I think people are living longer because they're treated in an office-based lab? I'm sure they're getting very good care. I think more importantly, the right patients are being chosen for outpatient care. And when hospital care is needed, then the right patients are being chosen for the hospital-based centers. What if you're a doctor that brings your patients to both? So we looked at operators who practice both in office-based centers and hospital-based centers. Same outcomes on the left, major lower extremity amputation or death. On the right, major lower extremity amputation. And again, the outcomes were in favor of office-based centers. And again, it's the same doctors doing these procedures. So it's just, we're picking the right patients in the right settings, and we're being responsible based on these data with who's getting care where. And more studies than just ours have shown this. This is a group that published in the Journal of Vascular Surgery in 2021 and showed, again, the safety of outpatient practices, both for venous and arterial intervention. So a nice profile that really highlighted on a smaller scale, but what we showed in the prior data. But, people then look at these type of curves. And if you look at the outpatient center, there are more peripheral vascular procedures being performed. In red here is office, if blue is outpatient, and black is inpatient. And if you look at repeat revascularization or peripheral vascular intervention, there is some signal that more procedures are being done in the outpatient center. So these are the things that we need to protect about and justify to protect this space, because these data do exist. And again, it's hard when you look at a large scale data set to explain it, though very often there's explanations here, but they get lost when you move away from the granularity of the data. So the next and final question I want to answer before we move to the conversation is atherectomy harmful? So we talked at the beginning about how atherectomy really grew as outpatient practice has grown. We talked a little bit about how we are able to bring these devices in a more streamlined fashion to the market. I think people using them feel that they're important. I know when I use them, I feel that I need them. And then the question is, are we harming our patients by using them? And I think that's a really relevant question. So we did 2 analyses on this. I'll present in just the next few slides. The first one was from the National Cardiovascular Data Registry. We had the Peripheral Vascular Intervention Registry. And this looked at both in-hospital and procedural outcomes with or without atherectomy use. And we were looking really at procedural complications for the full cohort, and then we had an additional cohort that had longer-term outcomes when they were linked to Medicare data. And this is a really nice demonstration of where we can use our registry data to support our practices. So you can see about a third of patients were treated with atherectomy out of the 31,000 patient cohort. And there are the flavors of atherectomy on the right, primarily driven by directional and orbital atherectomy. On the left here, you look at unadjusted and then adjusted outcomes. There was no difference between the two, but you can see the granularity here. And if you look at just in-hospital composite events of all the events listed on the right, the frequency events were, if not the same, slightly lower numerically in the atherectomy group. When you look at in-hospital outcomes on the right, broken down by the different events, including procedural dissection, embolism, major bleeding, you can see blue is atherectomy procedures and green is without atherectomy. Dissection was less with atherectomy. Embolism was slightly more. Amputations were slightly more in the non-atherectomy group. So, again, these are the real-world event rates for using these devices, primarily in a hospital-based setting, but again, in real, all practitioners, many of us probably are part of this registry. When you look at this going out to 1 year, again, atherectomy is blue and non-atherectomy is green. You can see trends that we found a lot in these large-scale data sets. Again, the use of repeat interventions are a little bit higher for people who are in the atherectomy bin, but the freedom from surgical revascularization is lower, a little lower risk of amputation as well. And so these things really help support the safety of atherectomy. This wasn't an efficacy study, but really demonstrated that complications were quite similar between the 2 approaches. We then looked at this in a much larger group with a much larger amount of time. And you can see here, this is published in Neurointervention. Blue is no atherectomy, red is atherectomy. And if you go out now several years, there really was no increased risk of any major adverse limb events or amputation death with atherectomy devices. So when we talk about safety of these, we are not seeing on the epidemiologic level any risks that are outperforming other approaches to endovascular intervention in this data set. And if you again look at the harder endpoints and changes in care, amputation were slightly lower in the atherectomy group. The need for surgery was lower as well. So again, just the ability to use atherectomy to avoid surgical bypass in the right patients who either may not qualify for it, may not have access to it, may not have a conduit for it, seems to be well represented here in this data set. And lastly, when you look at all of our vulnerable populations, older and younger, kidney disease, diabetes, female, what type of peripheral artery disease you have, really consistency in the safety of atherectomy across all these important subgroups. Lastly, quality of life. This came out after Best CLI, and it's interesting. If you look at the Best CLI data, and just to remind everyone, this is surgical revasc versus endovascular revasc. The outcomes favored surgical revasc and Best CLI, driven by the technical failures in the endovascular arm and the need for repeat interventions in the endovascular arm. But if you look at the 1-year quality of life outcomes, it hasn't been published yet. It's going to be coming out soon. They were quite similar. So even if patients did need another intervention, they ended up with very similar quality of life at 1 year as those who had surgical bypass. These are data from the Liberty 360 prospective study that was run by Jihan Mustafa and others, sponsored by CSI, primarily looking at patients who were treated with orbital atherectomy. And very similarly, we saw long, durable quality of life improvements with peripheral vascular intervention, a majority of these treated with atherectomy. But, I'm just going to end with some cautionary tale here, and then, again, we'll move into discussion. We have to be strategic here. I think that there's a lot of attention here, but there are always outliers, and we can't control the outliers, but we can control ourselves. And I think that, the data it can be used in the wrong way. And I'm showing you the data as someone who is trying to be even here and really understand the procedure and the patients and the needs of the field, but that can be easily twisted. And I highlighted before that, when you come out and JAK interventions with the study showing that over half of interventions need atherectomy, and that they're being driven, they're driving the cost of peripheral vascular intervention, and they're also being, tied to one site of service. That's when we end up with the New York Times article. And so we need to figure out the best way to demonstrate that these are the right tools for the right patients and they're necessary, and that reimbursement is really tied to the sophistication needed for these and the illness of the patients and the acuity of care. So, I would just, highlight 3 comments here. Is atherectomy used more frequently in ambulatory settings? I think the data has been supportive of that. Do patient outcomes differ by clinical settings? We haven't shown that. And again, I think a lot of that is because people are hopefully picking the right patients for the right clinical setting. Is there long-term harm associated with the atherectomy devices? And hopefully I showed you that is not the case. Now, lastly, and I'll move to my final slide, should we be more strategic with our use of atherectomy devices? And I think that's really where the discussion needs to go, is how do we support this field and protect ourselves, protect our colleagues, protect our patients, and do a better job moving forward. And, if we think about the bin of improving our practices and outcomes for peripheral vascular care, there's a lot going on right now. There's a lot of society involvement. OEIS, SCI have really looked at endorsing and developing registries. OEIS has a wonderful registry that is necessary to demonstrate quality and safety. Appropriate use criteria comes up a lot. Should we have more appropriate use criteria in place to protect ourselves? Do we need reimbursement changes? And again, this is what's come up. This isn't what I believe in, but, do we need prior authorization? Do we need value-based reimbursement? And this is where we're getting in trouble right now and where we're seeing a big shift. And then accountability. Do we need audits and public reporting scorecards? And so, these are the possible pathways. If we do nothing as a field, we're going to be stuck with all of these, and we're going to be stuck with the really challenging space, which is already what 2024 is showing us. So, it's important for us to figure out how to make this a manageable space for us to really have a long-term, reliable and successful practice. So I'll end here. This is our group generated a lot of that data that we showed you here back here in Boston, and my personal group doing a lot of this research. And I just thank you everyone for your time. I'll stop sharing here and be available for some questions.
Well, thank you very much, Eric. Wonderful presentation. So we'll open up for a discussion. We have Sahil here, who is in a hospital-based university practice. We have Nilesh Balar, who's a vascular surgeon, who is in a hospital as well as outpatient practice. We have Eric Dippel here, who is pretty much a strictly outpatient practice, and then myself, who does both outpatient, ASC as well as inpatient practice. So we have wide variation of our different practices here. So, let's start with Sahil. Sahil, this is a big problem, because as we own our centers and we see the shift in pre-authorization, and really affects the patient care. You have a CLI patient who really needs to be done very quickly, and requires a pre-authorization for a vascular intervention. That's the law says that the insurance company is allowed to respond up to 72 hours right now. So, and I don't believe that law is about to change anytime soon. So now I think the minimum, the only way to get around it is to admit the patient through the emergency room in the hospital to try to get them done sooner. So I think this is becoming a huge issue, and I'm sure Eric's facing this as well, and Nilesh and everybody else. So what are your thoughts on, how can, as a specialty, can we fight back?
Well, Raj, it's a longer conversation. I think first, we're not immune in the hospital setting to the same market forces and insurance related delays. And you're right, we do have access, maybe perhaps more readily, to admitting the patient or using other ways to get patients in for care, but the capacity crunch in hospitals remains an issue as well. So there's lots of competing priorities and complicated issues that prevent us from getting timely care to these patients. There's also increasing evidence that the time and rapidity of revascularization has an important impact on long-term outcomes. So there will be more to come about this. I think Eric's, final sort of throwing down of the gauntlet is exactly right. If we don't police ourselves, somebody's going to police us for us. And so we need to, as a community, come together and achieve consensus. The problem has been there's been a little bit of tribalism that has been perceived as a guild mentality, with one specialty competing with another. And I'm actually not sure. I spend more of my time with vascular surgeons than I do with a lot of the other cardiology specialists within my practice. I think as a community, those of us that really take care of patients recognize that, as Eric said at the very beginning of his talk, we're all in this for the best care of our patients and for their best interests. And he, I think, demonstrated elegantly that outcomes are similar despite venue of care. And there's some nuances in maybe the frequency of repeat revascularization, but the hard endpoints are largely the same. And I think in order to support the narrative that we're doing this for the best of the patients, it's going to need some of Eric's expertise and that of others to show that the economics make sense. And then I think one of the things that's another elephant in the room is that we don't have reimbursement for drug-eluting technologies in the ambulatory setting. And we all recognize that those are the techniques that will help reduce repeat revascularization and probably maybe even tip the scales to ambulatory settings being superior by a wide margin, maybe, to hospital-based care. And then the last point that Eric made, which I think is a nuanced point that people don't realize, is that docs who work in both venues select their patients appropriately to go to either venue of care. My perception is that patients that come to the hospital are generally sicker and have more comorbid illness, requiring more intense care. And nevertheless, their outcomes are similar. So I think that we as docs recognize who are the best patients for either venue. We need help from our regulatory agencies and our payers to provide the best tools for care. And it's not atherectomy that's the problem. It's the lack of ability to treat with drug-eluting technologies in the ambulatory environment with the same level of reimbursement that we require that's impeding care. And so how are we going to get there? We need all of our communities to come together. The carotid example is yet one of many examples that shows when tribalism prevails, we get nowhere with the payers. And it took us, 15 years to get a coverage decision for carotid stenting when there's been ample clinical data demonstrating equipoise. We are heading in the same direction if we don't get together. And so that's where we need leaders like Eric and others to kind of bring everybody together. Eric has a unique way of bringing the communities together. So I say we nominate him to be president of all vascular societies.
Nilesh, what do you think?
Couple of things that comes to mind. I think tribalism is the right word, because if we start fighting among ourselves, the beneficiary is always going to be the insurance company as well as the hospital administrator. The biggest thing which I see from vascular community has been because they get stuck with, not complication, but doing amputation. They feel that they have been deprived of the initial access. And it's a human nature that anybody who gets shafted with the end results where they have to do the amputation, they don't feel very good about getting involved in the last stages. And that's what causes this whole issue to be prominent. And among discussions with some of my colleagues, that has always been, oh, I got called in the middle of night because somebody did something as an outpatient and the patient ended in the emergency room. And those are the bad presses that we get. If we are going to collect the data, I think one of the data points should be, is there a difference between the rate of amputation but for a procedure that is being done by whosoever what's the ultimate amputation rate, whether a surgeon does atherectomy or interventional does or cardiology does. Is there a difference in the rate of amputation? Then second thing is by the side of the procedure, is there any difference in the amputation rate? If we can nail those down, then I think the way forward would be to form alliances or groups where they don't feel that they are just taking care of emergencies while the other people get to rest at home when complication occurs. I think that's the biggest driving point, and all my SVS meetings and other stuff that we talk about. The beneficiary, we keep on fighting, and every time I see that the insurance companies benefit, we complain against each other, not reaching any results. And pre-authorization, I think, should end in these things, especially if they're managed Medicare or Medicaid. I mean, Sahil probably knows better. In New York market, we have about 4 or 5 pages to be filled out, especially with some managed Medicare programs. And that takes not 72 hours, 15 days to respond. So you can never do a emergence, I mean, CLTI. If you see a patient like that, 15 days, I would rather just schedule him for an elective amputation than do anything. And atherectomy, some of our insurance partners have put down 40% of Medicare. I mean, you and I both know at 40%, I have to sell my house to treat those patients. So I think there are a lot of issues, but as a group, if we cannot control ourselves and we can't form a working relation, this is probably going to continue. And I look forward to creating an alliance where we all talk the same language.
No, I 100% agree. You know, Nilesh, you and I talk about this all the time, and you know, there's a lot of work to be done. You know, Eric, you have I'm talking to Dipple, and that you have had a lot of exposure to recent public, criticism that has come out. You know, is there some kind of a societal force that can, fight these things back? You know, we don't have to use the same exact media. There are many other, competing medias out there that can also publish something positive. Because right now it seems like that the floor is for people, those who are just publishing almost all negative stuff, especially I know a couple of people, I won't say their names here, but I was just with one of them in a meeting, and was against was very similar tune, that we were all crooks.
Yeah, I first of all, I want to congratulate Eric Sosumsky. That's a great presentation. It really kind of laid out everything and had some very nice data. I think that there's a couple things that I was taking notes here. There's a couple things that I could talk about, but if you want to cherry pick out data to just paint a negative picture, you can certainly do that if you want to. But I'll just give you my personal experience and what I've been through. I practice primarily in an OBL right now, and 100% of the reason is not because I want to make money or not because I want to do more atherectomy. It's 100% of trying to get away from hospital administration. 100%. When they tell you to hop on your right foot 3 times and spin around in a circle 4 times before you do this, that, or the other thing, it takes the physician out of the healthcare equation. And you're no different than just somebody that's serving food in the cafeteria. You're not in the center of healthcare anymore. And being in an OBL setting puts the physician back in the center of healthcare. And I think that is critical for decision-making for what we do for our patients. Nobody wants to have bad outcomes. I don't want to do repeat procedures on people. I want to be able to do one procedure and cure them. But that's not the world we live in. Unfortunately, we still have limitations. Going to the issue of randomized data, I'd like to talk about that for a second. Everybody claims there's no randomized data for atherectomy for this, that, or everything else. But I'll point out that most randomized data is not real world data in the first place. Most of the inclusion, exclusion criteria in the randomized trials primarily designed to get the device approved, but they're really not representative of 90% of the population that we see. And so we have to make some kind of clinical decision and extrapolate that data into the patient that's laying in front of us on the table. In my experience, I was involved with the Excite ISR trial, which is a randomized trial for in-stent restenosis and laser atherectomy. That was published back in 2014. We started planning that several years before that. When we started planning that trial, there was no FDA-approved device for treating in-stent restenosis in the femoral popliteal arena. Concurrently, there was a DCB trial going on and also a Viabon trial going on. Both of those trials, all three of those trials, the comparative arm was plain PTA. All three of those devices were better than PTA. All three of those devices got FDA approval for treating in-stent restenosis, but none of those devices were curative. Those devices all had late failures and patients came back. Interestingly, if you look in the laser data and you look at Rutherford classification at 6 months, if you had plain PTA, you had a 7 times worse clinical outcome at 6 months than if you were treated with a laser alone. So just treating with a balloon is not the answer, and it makes people worse off. Now, if you extrapolate that further, there are no randomized trials, and there never will be any randomized trials that compare combinations of those devices. Laser plus DCB, laser plus Viabon, Viabon plus DCB, all those outcomes, you could have innumerable permutations of how you could do randomized trials if you really wanted the answer. But at some point you have to say, look, all three of those devices are better than PTA. What if I start combining those in my clinical practice? Maybe I will have better outcomes. And again, I can continue to talk forever on this, but I'll just want to finish this. If you're not capable of doing an intervention in the hospital, then you certainly shouldn't be doing them in an outpatient setting. And that's part of the problem is we do have operators both in hospital and out of the hospital that really shouldn't be doing these in the first place. And those are the ones that are generating a lot of the bad images or bad press, in my opinion. The last thing I just want to say to kind of tie this all together is I think that PAD is like every other disease state, heart failure, cancer, or whatever, it's a continuum. When you look at the outcomes of CLI patients, they have a 50% 5-year mortality, and that hasn't changed in 20 years. Those people have a worse prognosis than most all forms of cancer. And yet, if you consider claudication to be stage 1 cancer and CTLI or CLI patients to be stage 4 cancer, imagine a woman that has breast cancer that comes into her doctor's office and has stage 1 cancer, stage 1 breast cancer, and we say, well, you're not sick enough to be treated yet. We're not sick enough to do anything to you yet. Go home and just exercise and you'll be better. And then come back when you have stage 4 cancer and then we'll do something for you. It's insane to think about that. I've said for 20 years that if grandpa walks to the mailbox and has chest pain, we say, go to the ER. If grandpa walks to the mailbox and his legs get tired, you're just getting old. And that's how we treat these people. We need to treat these people like they have a disease state, and treating them in an earlier disease state is going to make them better off in the long run. And I'll just kind of end there. I could talk about this for hours, but I mean, there's a lot more data, a lot more things we could discuss.
I think that what you said, the last thing about claudication, is the perfect segue into our next presentation. So it's an honor to have Dr. Chris Pollack, who has over 30 years of vascular surgery experience. He's the Chief Medical Officer of the Vascular Care Group in Boston, Massachusetts. And this is exactly his next topic. You know, this obviously, I said earlier at the start of the program that one criticism was about atherectomy, the other criticism was about claudication. So Chris is going to talk to us today about, you know, whether is it fair to treat claudication rather than just, you know, treating them conservatively. So it's great to have Chris. Chris, can you share your slide, and can we hear you now?
Yeah, can everybody hear me okay?
Yep, great, thank you. Yeah.
I apologize. Let me see if I can get my slide up and running. So I just wanted to sort of as I'm getting my slide up here, I just wanted to comment on what Eric was just presenting. I think we have to think of all the tools that we have in our toolbox as exactly that. They're not inherently good or bad, evil or wonderful. They're just tools, and we as the clinicians have to decide what the best way to use these tools are and how we can best help our patients. And I almost think this comment or this topic needs 2 slides. I'm not going to do it, I promise, but I actually had sort of my atherectomy slide set up too, because I actually do think for vascular surgeons, it's critically important for us to understand there are clearly cases where plain old balloon's okay. We have wonderful new technology with drug-eluting technology in balloons in terms of stents. But clearly there's a role. Clearly there's a role for us to be able to manage patients with severe calcium, in-stent restenosis, as Eric mentioned. And there's clearly times when we're all very aware as clinicians that balloon or even balloon and stent alone does not work. And so the role for some type of device, whether it's some type of device to break up calcium or remove it, that really is critically important for us to understand that there's an important role for that as well. So I'm going to give part of a talk here, and then I'm happy to sort of segue into the atherectomy debate as well. Let me see if I can share my screen here with everybody. Let's see. So I'm going to close one here, close another. Can you see this? Screen sharing says it's disabled, but I don't know if I can.
We see you. Let me see if I can.
I'm hitting my share screen.
Okay, try now.
Should be here now.
Okay,
can you
yeah,
see that?
we can see it now. Yep.
Okay, let me go to slideshow. So I thought it would be important to provide perspective, as Dr. Davi had mentioned. As a vascular surgeon, I've practiced in an academic setting. I was at the MGH for close to 25 years, ran a training program, ran a department of surgery at one of our community hospitals. And I, like Dr. Dipple, about only 3 years ago, decided that from a patient management, patient care standpoint, this was the direction we needed to be headed. And so I actually have now transitioned into a chief medical officer role, still as a practicing clinician. I still practice 50% of the time in a hospital setting in one of our MGB community hospitals. But I also practice half the time in the OBL, and there's absolutely no question that we can provide the highest quality care there. So can everybody see that first slide?
No, we can see just fine.
Okay, so this is a bit of a spin, but this really sort of focuses on treatment of claudication and also the debate when with claudicants can we intervene if there's smokers as well. So we all realize that, as was mentioned earlier, claudication is just a marker for patients who are going to have systemic disease. So all of these patients need the medical management that we're providing. But why do we care about smoking? Why do we care about PAD? We know that these can have effects of decreasing wound healing, effects on coagulation, effects on cardiovascular disease. And in fact, when I see my patients with our medical students, I'm not only talking to them about lifestyle activity, but also medical management, antiplatelet therapy, statins. And we really have to become partners with our cardiology colleagues, with our primary care colleagues, as we manage the entire patient, as I think Eric and Erica just managed. So here's the SVS criterion, the recommendation for treating intermittent claudication. I think this is important just that everybody knows what is being put out there and what is being promoted. This was done to sort of a RAND appropriateness method standard. So basically, this is a group of pretty bright people from across the spectrum who have gotten together to say, this is what we think the literature supports. This is what we think you should do. The reason this is so critically important is because insurance companies, the federal government, payers are all looking to our societies, whether it's SIR, whether it's the American Heart Association, whether it's the SVS, to decide, are we going to pay? Are we going to reimburse for this? So I think it's important for everybody to understand what is out there or what is being published. Now, there's a big disclaimer. So I was on the review committee that looked at this for the SVS, that AUC should not be interpreted as a requirement to administer treatments. And we changed some of the terminology because when they started, they were saying it was either appropriate or inappropriate. And that phraseology just does not work. It's not valid. So we changed that to benefits may outweigh risks, risks may outweigh benefits, or indeterminate. And I really think it's important for us to understand that these guidelines are exactly that. They're guidelines. But as Eric, I think, pointed out earlier, we're really making individual decisions based on your expertise, your interaction with the patient. So I apologize. It's a very busy slide, but I think the important takeaway, take-home message is, one, we want to work on smoking cessation, and I work very hard on that. And it is possible to get patients who've smoked for 20, 30, 40, 50 years to quit, but it is the most addicting substance I know. The SVS felt so strongly about this that they broke their category down into a non-nicotine user and a nicotine user, if you look at the far end of the table here. So I do think it's important to take that into consideration. Then you can see here, how limiting is this in terms of their lifestyle? Is it severe, which is at the bottom here, moderate, or mild? If it's mild, we have time. This is not a life-threatening condition, at least immediately. It's not even a limb-threatening condition in the early stages. So we do have time for statins, optimal medical therapy, as you'll notice, working on a walking program, discussing and getting them involved in other risk factor modification. And so early on, I think everybody would agree we would focus on that. But I think it's important to remember down in this severe category where we have patients who can't function, they can't remain independent. Maybe they can't shop. Maybe they can't take care of themselves or their loved ones. Maybe they're still working and trying, the classic example is the postman or the mailman who has to walk for their job. And so in these patients, while I do think the medical management is critically important, that's where I think our interventions do come in. So I apologize here. Again, it's a little bit hard to see, but this is sort of focused on fem-pop disease. I think one of the things we really do now is focus on getting patients active, keeping them active as part of a structured walking program. Unfortunately, our government payers, in their infinite wisdom, do not reimburse sufficiently for paid walking programs or paid exercise programs like we do for stroke rehabilitation, like we do for heart and cardiac rehabilitation. I sincerely believe we need this. But then as we start talking about interventions, down here in the severe category, you can see there is actually quite a bit of green. Once again, here's a slide talking about where we stand in terms of completed exercise therapy. And this is actually their current recommendations related to open surgical therapy, sort of at the top on the left. And as we look at initial and completed exercise therapy, again, for mild and moderate disease, everybody would tend to agree we need to get them involved in risk factor modification. But once this becomes disabling, once this keeps them unable to function, remain independent, do the things that they need to do, that's where I think both our open and our endovascular options very much need to be considered. And as a surgeon who's been doing bypass for 25 or 30 years, I will tell you, while I truly believe that bypass does work, there is absolutely no question in my mind that the need to harvest saphenous vein, make a long incision in the leg, find a good conduit that's not been diseased or used for something else can be challenging. And once we get away from a single segment of greater saphenous vein and we go to composite arm vein or prosthetic conduits below the knee, then the patency rates go down significantly. And that's where I think endovascular therapy has completely revolutionized our ability to treat and manage patients. So again, this early algorithm is a careful documentation of history and physical exam. Non-invasive studies, I think, are critically important. We all have to become facile with understanding what their baseline perfusion is. We have excellent vascular techs who also provide arterial duplex, so we can identify stenoses in the SFA, the popliteal, the tibial. Once again, we've come up with our own structured walking program. It's not supervised. Many of our patients now will have Fitbits and different apps that they can use as well. Obviously, and I'm certainly not the most qualified to talk about this on this forum, but optimizing our medical therapy, including aspirin or other antiplatelet therapy, statins, diabetes, hypertension control. And I also spend a large amount of time talking to patients about, diet and thinking about what they're putting into their bodies, and then the smoking cessation program. I will spend a little time on smoking cessation. I know this is tough, but nevertheless, there's actually data out there showing that we can have a huge impact on our patients by focusing on this, not only referring them to programs, but thinking about nicotine replacement, counseling, that type of thing. And this was a paper that actually was presented at one of the recent SVS meetings, talking about outcomes of lower extremity bypass in smoking claudicants. And what they found, they tried to propensity match it, looking at never versus former and current versus former. And what they actually found is the results were actually quite good in both. Certainly the current smokers, as you can see, in terms of amputation-free survival on the bottom curve, were not quite as good. But once they quit, they actually did quite well. So I'm going to move this bar here. So no difference in limb salvage and TLR. And here's another paper that was presented again from the VQI. This is again a meta-analysis using a large database. However, I think it's important to realize that for patients who have smoked previously, again, this was sort of a matched pairs. And once again, here's the results. No difference in survival, limb salvage, reintervention, or amputation-free survival. There was a difference here, again, at a 5-year data point with 1,451 pairs of current versus former smokers. But I think our late algorithm is very careful follow-up, very structured in terms of their walking program. But then after that, selecting patients with reasonable anatomy, reasonable risk, again, those who are severely limited, and our patients clearly benefit from being able to stay independent. One of the things in vascular surgery in particular, and I think in vascular medicine in general, that we do poorly is focusing on outcomes that our patients care about. And I think Eric would agree with this as well. We focus on patency, we focus on limb salvage, and I get that. That's critically important. It's the core of what we do. But one of the things that we don't pay enough attention to is how do our patients feel about what we do? How are they functioning in terms of their lifestyle, sort of the walking impairment questionnaires, the quality of life status? That is critically important to not only our elderly patients, but our young patients who are still trying to remain independent, working, taking care of family members and friends. So I'll stop there, but once again, I'd really like to emphasize how important I think it is that we understand what the data is about all of our different modalities, not just atherectomy, but angioplasty, drug-eluting technology, shockwave. All of these are just tools for us to take better care of our patients. Thank you.
Thank you very much, Chris. So, let's open up for discussion for a few minutes about claudication. Nilesh, Dr. Ballari is a vascular surgeon in New York and works both in outpatient, inpatient world. Nilesh, obviously there's a lot of, criticism about treating claudication now, and, some of your colleagues at the SVS are traditional SVS leaders, they feel that the claudication should never be treated, Now, I find a lot of patients, at least in our practice, where, that structured or a supervised walking program is probably not possible because the patient's so limited already. And I think that I do like Dr. Kolek's comment that there is less emphasis on how patient perceive our interventional procedures and the outcome of those interventional procedures. And we are so much dialed into restenosis and things of that sort. What are your thoughts on this topic?
Raj, you're absolutely right. And earlier, Eric Dippel was talking about treating this as a disease process, just like diabetes. I wouldn't compare it to cancer because that's a very different category. But diabetes, you never get cured. PAD, you can restrict or slow down the process. But when it comes to treating claudication, I agree with a portion of it. When the inexperienced operator tries to do below the knee, that's where the problem lies, that there are indiscriminate operators who don't have the skills to go below the knee, especially if they're single vessels, and that leads to bad publicity as well as bad outcomes, because now you have ruined all the chances of limb salvage when it's done inappropriately. So for below the knee, there is definitely a gray line where each operator should decide if they should jump into that kind of claudication patients. Above the knee, I think it's appropriate depending on what the patient understands, that what are his long-term outcomes, because they are going to come back as long as the patient and the treating physician knows what to expect out of the treatment. And if you look at all the studies, whether they are randomized or not, 60%, 50 to 60% are all claudicants. So I don't know why there is such a huge debate about whether we should treat claudicants or not. And as far as personal practice goes, being in Bronx, I probably see 1 or 2% of my patient population that are claudicants. And I don't think we have any way of telling or putting them on any supervised exercise program because they're never paid for. And you can tell as much as you want, they are not going to follow any of those protocols. So you have no idea other than documenting that we tried 6 months of conservative therapy. So those are real life limitations that we have, and it goes on either side. As long as people are very cautious about what their personal limitations are in treating these patients, I think there would be a better outcome.
Eric, what are your thoughts, about, claudication? You must be on mute, Eric.
There, sorry about that.
That's okay.
Yeah, I think it's a difficult situation. And I think that a lot of it has to be your clinical judgment and the risk stratification with the patients. And I agree with 100% with what Chris said. I think that was a great talk and a great summary. But what is frustrating to me is when you get denied pre-authorization or denied payment from an insurance company just because the word claudication is on the paper or on your H&P or something. That's completely inappropriate because we've criminalized treating patients that have symptomatic disease, and we shouldn't be doing that. Do I treat every single claudicant with an intervention? Absolutely not. But if a patient comes to me and says, hey, I want to do this, that, or whatever, and I can't, then I think it's very justified. And I'll give you probably the biggest example of malpractice I ever committed was I had a patient a long time ago that ran marathons. And he told me, he said, I get out to about 14 miles and my right leg starts to drag a little bit. I'm like, Christ, I can't even walk 14 miles. Okay. I did an angiogram on him and he had a mild, maybe 50% stenosis in his external iliac that I really felt guilty about treating, but I put a stent in it and he comes back to me, he said, Doc, I've never ran a faster marathon time. And he was so happy. And I was like, I wouldn't put a stent in that in 100 other patients, but this guy wanted to have a better quality of life and running marathons. Now I have some patients that their daily activity is walking from the couch to the refrigerator. They don't need to be able to run 14 miles. So you can leave the 99% external iliac artery stenosis and leave it alone. And so you have to have some kind of clinical judgment, but when you have a blanket denial from insurance companies just because they're claudicants and because we've criminalized treating claudicants in the lay press, I have very strong feelings about that, and it's completely wrong. And we have to get away from that because patients are patients. They want you to make them feel better. And it's hard for me to tell them, I'd like to treat you, but nobody will let me treat you. And that becomes the bigger problem. And you know, Chris brought up the quality of life, stuff, and I think that's critically important. When I was in my fellowship back in the late 90s, the only stent that was available for SFA at the time was the wall stent, and it had horrible outcomes. I mean, 30% patency rates at 6 months. And so the blanket recommendation at that time was you should never put a stent in the SFA. That was the recommendation. Well, along comes nitinol self-expanding stents, and they had better results. I published a paper back in 2004 looking at task D lesions that we stented 30 centimeter occlusions with a self-expanding stent, 88% freedom from revascularization at 1 year, and their quality of life indicator on the walking impairment questionnaires were through the roof. These patients felt better and their arteries were staying open. So I was asking the question, why should we not be stenting these legs? Just because the wall stent doesn't work doesn't mean there should be a blanket statement. Fast forward, now we have drug-coated balloons. We have drug-eluting stents that have even better patency rates. I can't think of why we shouldn't be treating these patients if the patients are impaired in what they do on a daily basis. And we have to get away from criminalizing treating claudicants.
So I would jump in there too, Eric, and say I think you're right. And unfortunately, I don't think it's just claudication. I know that's what we're focused on for the moment. But the challenge is, I think the insurers, the payers, and I hate to say it, but it's true. They're looking for excuses not to pay with the pre-auth and everything else. I mean, I have patients with critical limb ischemia coming in who desperately need something because they've got rest pain and skin breakdown, and we're arguing with payers about that. So my only point with all that is we can complain about it. We can get on the conference and gripe about it. But the bottom line is we, like Eric Shashimsky does, and Eric, I think you do as well, many of us, we need to be involved in publishing things, talking about things, but we also need to be involved in interacting with insurers. There's numerous times I can think of in my career where a new technology has come out. It clearly benefits patients, but it's experimental. And we have to go to Blue Cross Blue Shield or CMS or, whatever your regional carrier is. And these days it'll be national carriers. It'll be Aetna, it'll be Cigna, it'll be Optum. But we have to be involved in presenting data, patient satisfaction data, and yes, some of the patency data and reintervention rates. And we also have to show that in the right hands with the right indications and the right follow-up, that's the other key, the right follow-up for these patients. It's not one and done, that we can get exceedingly good long-term survival, freedom from amputation, functional status, all these things that are important to us and the patients and to the payers, but we have to be involved.
Yeah, I agree. I think that where some of the bad operators, the bad press comes from is, even when you go back and you look at the Partners trial, which came out almost 20 years ago, and looking at patients that have PAD and diagnosing who has PAD, only about 10 or 15% of those patients really had true claudication symptoms. I mean, 50% of those patients had atypical leg pain. And so that's where it becomes difficult from a clinical scenario. And so patients come in with varying types of leg pain, and I see all kinds of consults for leg pain, but I don't stent everybody that has leg pain. A lot of it's radicular pain, a lot of it's arthritic pain, etc. As a clinician, you can't just indiscriminately be putting stents in everybody that has leg pain, but that's where the overlap is. And so I think there's a problem, because when you look at that, the people that just say, oh, my leg hurts, and they get a stent, well, it's the same thing with the coronary artery disease. They have chest pain somewhere between their chin and their belly button, and they get a stent, and they come back, and the next day they still have chest pain. It's because it had acid reflux for the whole time. It was never ischemic pain. But then when you talk about the pain issue, I think that one of the things that you get the bad press from is that the payment system is 100% flawed, but for the outpatient system, that's all through Medicare Part B. You know, OBLs are getting paid through Medicare Part B, and it's through the physician fee schedule. And so the reimbursement to a physician seems to be inappropriately higher in an OBL than in a hospital setting, but hospitals are getting paid 40% more through Medicare Part A to do the same procedure. And so insurance carriers are actually paying way more to have procedures done in the hospital. And nobody seems to understand all these issues. It's a very complicated subject, to be honest with you.
Yeah, to add to that, you said we have to have the data. The most puzzling thing for me, and Ashil alluded to that, we know for sure now that DEB and DS has better outcome than the plain old balloon and bare metal stent. Why are we being criminalized or not paid to use it when we know for a fact that it helps the patient? In OBL, there is a difference. They just don't pay for that differently. And that puts our patient at a disadvantage where
Same
they
thing in the
get
ambulatory
treated.
surgery center. Yeah, same thing. They don't pay for DES and DEB, and I think which is wrong. And I really think that, you know, we need to get industry to the table with both, you know, a united front of surgical society, you know, interventional societies and radiological societies, and everybody comes together with the industry. And I think that that's the only way we're going to be able to change that, because it needs to be in the guidelines as class 1 therapy in order for us to try to get this change. And I think that societies will have to recognize that, otherwise they won't change the guidelines and it won't happen. Anyway, well, thank you very much, you know, for that's a very spirited discussion this morning on atherectomy and claudication. Chris, thank you very much for taking the time this morning from your busy schedule to do that lecture. And now is the time for journal notes. Dr. Vetrovic's here, I see him, and he's ready to go with the latest science. Thank you very much, George, for being part of this discussion. And showing us what you have in store for us today for journal notes.
All right, if I succeed here, I will bring up the presentation. I will share the presentation here, and we will be off and running. Let's see what happens. And
You see it.
did it. Good. We are doing better than I thought. Okay. And now I need to figure out how to move this guy so I can be here. So I thought I'd give it a little
Perfect.
cleverness.
Perfect.
Vetrovac vignettes.
No, I like that name.
It's not patented, but anyway. So this is what I'm going to cover three fairly recent articles. The first one I think has interest to everyone, and this is the issue of the declining cardiology board pass rate. And there was kind of a pro-con that was done in the training fellows and training early career section. The first three people are the individuals who are in early career training sessions. And the reality is that for many years, the pass rate for the board's first-time takers was about 95 plus or minus %. And this is not an accident, because and let me give the disclosure that I wrote questions for the ABIM some years ago for 7 years. So I know the workings. And it is not graded on a curve. And they make every effort to reevaluate questions year by year to make sure that when the test goes out, it's thought to be, as best one can assess, equivalent in terms of difficulty to the previous year. And there are these people that are called psychometricians that do testing, and we used to call them the psychos. But anyway, they make sure that this is true. And one of the things they do is they make sure there aren't major changes in the exam from year to year, which helps predict that it's stable. So this is clearly an aberration that happened. And you see starting, in 2020, 2019, 2020, it's been dropping to about 85%. And I would give you the added concept is, I think when we were writing questions for the boards, there was a great emphasis on not trying to be tricky. And we all felt that if somebody gets into a cardiology program and lasts through it, that unless there's a really terrible training program or something, they ought to be qualified. So this isn't a celebrity sort of thing. This is just showing that people have basic knowledge and skills. So this is a big aberration, and it has people twerk. Now, the students or the recent trainees and so forth wrote things that said that the board had actually tried, and this is after my time, to eliminate trivia. There was always this tension on the board. Do you not ask questions that only work on, involve 1 in 1 million people in the United States or in the world, or what is the level of very unusual things that you ask about? And the tension is that if you just ask about use of beta blockers, then cardiologists are no different than an internist, because they both do the same thing. So there has to be some gradation, and some of that is in knowing unusual things. Otherwise, they'd never be discovered. But anyway, the board has made an attempt to get rid of as much of this as they could. Pandemic's likely a contributor. Burnout of fellows and faculty and everybody is a problem. And of course, during the pandemic, they had fellows treating COVID rather than doing cardiology. There are the fellows and trainees, early practitioners thought that there ought to be a bank of questions available so that they could see where they stand. Now, the ACC provides some of that. So their recommendations were that the training director should be focused on training and get the time, and money is usually what it is. You can spend as much time as you want. As a question, do they pay you for it, to run the programs? And they usually don't pay well to do this. Time for education for the fellows, so they're not all doing just work. But encourage the fellows to do self-training at home. With all this work-life balance, there's been a move away from doing anything educational at home. Access to practice questions, as I said earlier, to identify deficiencies, and utilize ACC tools. Now, the response from a faculty member, Jeffrey Kuvan, has been on the board of the ACC, has been very focused on educational issues. It is a big part of this attempt to bring ACC and all the other cardiology societies into having their own board exam. And he writes the rebuttal saying that there are limits of COVID are real, but is it time to reassess the assessment? And while the summative evaluation at the conclusion of training is reasonable, there are likely alternatives or additional appropriate methods to evaluate the quality of the trainees. And what would these be? Well, using simulation methods, oral case reviews, objective structural clinical examinations, evaluation of non-clinical competencies, including professionalism, DEI, you can go down that list. Ensure that we are providing the right evaluation of our trainees, despite being sensitive to the COVID issues, and really need to reinforce optimizing this training experience. And the payoff is obviously improved board scores, but also doctors and better patient outcomes. So those are sort of the tensions that are going on. I have a couple of comments from training, running training programs and being part of the ABIM. I think the changes are multifactorial. If one eliminates all esoteric material from the exam, how do you really distinguish a cardiologist from an internist? Case presentations, et cetera. This has been tried before, even before my time. So you know this is old, but there used to be an oral component to the exam. And and that was eliminated because it was thought to be very subjective and so forth and so on. The patient would be the same patient for everybody having the oral exam, and they'd tell them what they had, tell the fellows what they had. There's some good stories. One important thing is this whole issue of AI, and this is going to be more and more important. And I think testing relatively of trainees' understanding of how that impacts practice might be an important component. And I think there needs to be time for teaching and learning, but some of this and should be expected by both faculty and fellows. So I think there are a lot of challenges here, and I'll stop at this point and see what the discussion is. It'll be interesting to see as we go forward if the scores come back up or if they remain lower and what the factors are. Raj?
Yeah, so I think that this is a real problem now, that the board exam passing rates low. In fact, I know one of the cardiologist's daughter had appeared twice, and she failed both times. And it's really, really very upset about it and very discouraged by it. I've heard this in other circles as well. And the re-cert exam has now other options from ABIM as well as from ACC. However, all those options require something to be done on a yearly basis. And I'm enrolled in one of those programs myself. And my take on that is that yes, it's slightly easier than taking a traditional 10-year test. However, it's an annoyance that every year I do a program and I'm just done with it, and while I turn around and here it comes again. So it's I wish it was every second or a third year rather than every year to having to do other modules. So I think there are issues both ways. The unfortunate part is that the ABIM has lobbied very successfully all the insurance careers that if you're not board certified, your reimbursement would be lower. So we have one partner that's not been able to be board certified, and I think that we have to restrict on what kind of patients she sees, because otherwise we're gonna, as a practice, gonna take a bath in lack of reimbursement. So it's a problem.
Raj, can I interrupt you 1 second on that?
Please.
I think that didn't happen by accident. I think when I was on the board, the ABIM had this idea that they would ultimately do certification for hospitals. So rather than the hospital having to decide who's certifiable and by what rules, if you were an interventional cardiologist, they would decide for the hospital on contract. It was a business proposition, and they would tie it to these exams. Now, they never quite made that happen, but there was a reason for this, I think, that was somewhat business related.
Yeah, I've no doubt. Yeah. Now we have a couple, Chris Skolek has run, vascular surgery training program for many years at MGH, and I think the vascular surgery is now, Nilesh, if I remember you telling me one time that he has a separate board now, right?
Yeah, I was curious. I was just going to ask the question. There's been a push within vascular surgery. We've been part of the American Board of Surgery, again, because there's strength in numbers, everything everything related to that. And yet vascular surgery many times has felt like a sort of an orphan stepchild, not appropriately represented. And, you know, a lot of decisions made about a field that many general surgeons and other surgeons don't know about. Thoracic surgery has an independent board. Colorectal surgery has an independent board. Plastic surgery has an independent. So lots of different areas. And I do think we have more in common with many of our cardiovascular specialists in terms of how that occurs. But you're right. I think there's always a concern when you get to these board levels. They're trying to generate revenue. They're trying to figure out best ways to certify or recertify. And I think that has to be an evolutionary process. But we have the same issues with vascular surgery. Is that every 10 years you re-up? How do you submit cases? I actually think there will be new technology coming along where rather than just an attestation that, yes, here's the number of cases I did and I took an exam, I'm doing okay. There really has to be some type of technical evaluation or component. One of the things I've been dealing with recently in my former role as a chair is, what do we do with practitioners such as ourselves, sort of in the senior level, as they get to the senior part of their careers? Hopefully, most of us will have colleagues and friends who are happy to step up and say, you know, have you thought about transition here, or whatever? But all of us are well aware of colleagues at the end of their careers who probably needed to slow down or step down or have other people intervening. And the problem is all these things are out there in the public media now, along with these other articles. And I think what it's done, it's undermined some of the confidence that the public has in physicians. And I'm looking in the chat message here. One of our audience members was talking about what's the role of medical ethics in cardiovascular training, and you know, how do we teach the big picture part of it? And I really do think that is critically important. And we talk about mentors, we talk about supervision, we talk about experience. We also talk about being able to technically be adept at doing what you're doing, as Eric mentioned, or as was mentioned before by Niles. Not everybody has the same skill set, but we have to have a common standard. So those are some of the things as a program director I used to struggle with, and still think we as a specialty, as clinicians, as practitioners, really need to think about. And at the same time, everything's becoming so focused on the business aspect. We have to be able to pay attention to that. But we really do need to make sure that we have a higher calling to do what we do. And I know everybody on this call feels that way. I'm sorry, George.
Yeah, I just wanted to follow up and support one of the things you said. I'm also chair of the senior section of the American College of Cardiology. We now call it Advanced Career because that's more politically correct. But the point is that with this new board coming about, our group is making some statements about it, that it's not reasonable to necessarily think that a physician that's going to be just doing outpatient as they phase out of whatever they did before and do outpatient, or if they're only reading CT scans or whatever, that they have to take a whole general cardiology knowledge base. And that there needs to be a way to have you be tested as you become more focal in what you do. And that how that's going to work out, or whether it will work out. But I think your point is really dead on, because there are physicians who are retiring, not because they couldn't do office practice, but they just don't want to go through all the hassles. And many of them we've looked at the numbers. A lot of people practice well into their 70s in some form, and maybe even part-time. And with the dearth of physicians, that's a need. And so we got to get smarter about this.
George, I just want to emphasize what you just said. I mean, on another level, I mean, this is why we have a shortage of airline pilots in this country, because the FAA mandates retirement at 62 or whatever, when these guys are still at their peak. I from a personal standpoint, I did a endovascular and interventional cardiology fellowship and I practiced both for many years. The last 6 years I've been an OBL. I predominantly only practice vascular medicine right now. I don't do pacemakers. I don't take care of heart failure patients. But in about 3 weeks, I have to renew my 10-year board exam. I don't know if I can even pass that. I mean, I've got to go back and relearn tetralogy of Fallot and general heart disease. And it's been a struggle. I'll be honest with you. I don't even know if I can pass a cardiology board exam right now. All I do is practice vascular stuff. I mean, it's real.
Yeah,
It's very real.
You make great point. And I think this is something we've got to get straight.
Well, to add to this thing, we are such a group of critically self-criticizing ourselves to the point that we want the highest standard. We want age, we want the dexterity, we want the people to have the technical skill as well as the mental acuity. And if you look at any other subspecialty or any other profession, including White House, they can't even formulate a sentence, but they are still there. Here we are talking about ourselves who are very functional. We do our job, but we still keep on subjecting ourselves to so much scrutiny that I don't know which is the middle path, because taking tests and getting all those scores is one thing. And in surgical side, as Chris pointed out, we have oral boards in our initial pass and fail, and we have the written boards, and we now have to do ongoing every 2 years. So 1 year I do general surgery, next year I do the vascular. So every year there is an exam, and nobody else in any other profession takes that. I think it should be starting from White House onwards, and then we should follow ourselves to that standard.
All right, let's carry on the conversation. George, what else you have?
I got a couple of other ones I'm resharing now. Let's see. Is it up there? I think it is.
Yeah, your
So
slide.
the next one I want to talk about is a publication, distal radial access for coronary procedures in a large retrospective multi-center registry, the CADRA trial, the Korean study. And CADRA, if you're interested, stands for Korean Prospective Registry for Evaluating the Safety and Efficacy of Distal Radial Approach. And I'll let you on your own figure out how that becomes CADRA. But the goal was to evaluate the safety and feasibility of distal radial access in daily practice. So they looked at 14 centers between September 2019 and September 2021. They screened 5,712 patients. They excluded a sizable number, and I'll show you that in just a minute, and wound up with about 5,000 patients for follow-up. This is the strata. They started with the 14 hospitals, 5,700 patients. They did distal radial access that they counted in about 5,000 patients. They excluded 735 patients, and I think this is relevant. Note this: the largest category was weak pulse. We'll come back to that later, but there are lots of other things here. And if you look at this, they start becoming small numbers relative to 5,000 patients. But there are some, you can always say, well, why did they exclude that? Were they, cooking the books? But anyway, I don't think it's a major issue, but I do want to point that out. One thing that was unique about this study, I thought, was they didn't do just hospital discharge. They did 1 month follow-up, and they got 94.5% 1 month follow-up, which is, I think, impressive. Let me summarize the results with their picture visual. Puncture success was 94.4%. Again, now they've excluded some that they didn't think would be good. I don't know that that's unfair. If they decided they could do it, then they tried, and they were successful 95% of the time. The co-primary endpoints in the study were a successful coronary angiography by the distal radial, And that was 100% successful. On the other hand, of the patients they were able to access. On the other hand, they also co-primary success was PCI success via the distal radial artery. And that was almost 99%. So they had an extraordinarily, by their definition, success rate. And then they looked at 1 month arterial occlusion based on palpitation, whether they could feel a pulse or not. So for the distal radial artery, it was 0.3%. For the radial artery entirely, it was 0.2% before discharge. So this is the end of hospitalization. At 1 month, it was less than 1% for the distal radial artery or the radial artery. So not shabby. If you look at the issue of crossover, how many patients crossed over, it was 6.7%. And I thought this was at least interesting. Almost 2/3 of those were patients who were able to be accessed from the radial artery, not the distal radial artery, from the same side. So the hassle factor of changing sides and all that was low, relatively low. 7.5% of the patients had to go to the opposite radial artery, and then 19% went to femoral. Bleeding was 3.3% overall. Different classifications, you see the numbers. I think that's pretty low bleeding. And then they looked at the predictors of puncture failure, and they had a host of things. There were 2 that fell out by analysis. Weak pulse was one, and the other was the experience of the operator. So if the operator had done 100 or more cases, they had a better success rate than those with less than 100. So interesting. Now, the editorial comment on this made the point that there are a lot of things that cause the occlusion of the artery, and they certainly didn't look at all of those and so forth and so on. So there's some critique about this just being really what happens day to day. So it wasn't terribly scientific in that sense, looking for etiology, but the numbers were low, and it was a real world practice. And one of the things they pointed out, they thought that this looking at puncture failure was something that could really be followed up on. For instance, they suggested that ultrasound was not a specific part of this, and maybe for the weak pulse patients that using ultrasound could improve that success rate. And of course, the operator experience, maybe there's an opportunity for simulation and some other things to improve that practice. So there might be a way to really improve this down the road. So I'll stop at this point and get a discussion going. But I thought it was an interesting kind of observational study that probably would be hard to do in the United States, but a more organized system such as in Korea made it possible. Comments?
Yeah. So in third world countries, now they're not really so third world countries, but in China and India, there is a fair amount of anatomical snuff box and distal radial access that they try to do. I've yet to, be a fan of it, because I'm not quite certain that how much really it adds to the procedure. Because I certainly don't think that it's going to make the procedure, technically, any better. And maybe perhaps the bleeding risk is a little low. Nilesh is a vascular surgeon. Nilesh, is there an advantage of going into the distal radial artery from a collateral palmar arch perspective, if there's an occlusion?
I don't see a huge advantage other than definitely for peripheral. I think it just lengthens the procedure. Your torque and other ability to get your wires through is a little more difficult. And if you're doing outpatient, maybe for the people who are not used to getting IPSI access that easily, it might be an advantage. Coronary wise, I can't comment, but doing an anatomical snuff box, I don't know if that artery is big enough. We still do occasional AV fistulas. And that is a real small artery. Trying to put a 6 or 7 sheath there, I don't know if it's going to be, it can get thrombosed and you may still maintain the patency of the radial artery. That's the only advantage I see. I don't do as much of radial access for any reasons other than going into iliacs if there is occlusions or sometimes trying to get renal. But other than that, I don't see much utility. And the cost of doing radial access for peripheral is probably much higher. In OBL, I don't know how much it is of a concern other than the safety of not getting hematomas from the groin access.
Yeah, then there is also issues of, at least, what we see in Brian Cluck, who's my, partner, who likes to do majority of his coronary procedures from the radial access. And I see, that there is radial hematomas and arm hematomas and things of that sort that do happen. So it's not completely immune from any kind of complications. Eric, do you do any radial to peripherals, and have you tried distal anatomical snuff box access or anything like that?
The short answer is no, and only when I need to. When I was a fellow, we accessed things where we needed to access things to get to where we needed to go. And we did brachial, we did radial, we did pedal when we had to. But really, in my opinion, this radial revolution has been industry driven, 100% industry driven. 15 years ago, one particular company came out and said, if you don't do radial access with our new sheath, then you're an inferior physician. And everything went to a radial approach at that point. And there may be some advantages, but with ultrasound guidance and a microneedle access to the femoral artery, the bleeding complications are extremely low. With closure devices, patients can get up and walk in an hour or two. It's not a problem like it used to be. And quite frankly, current fellows are not even trained in how to access femoral arteries, and they're taught that the only way to access the body is through the radial artery. And I'm quite interested to understand how you can reach a toe from a radial artery when you have distal embolization. And so, I think there's a place for radial access, but I'm not a fan of it. And 99% of my cases are femoral access. And I think you can, from the middle of the body, you can go north and you can go south and get anywhere you want to go from the femoral artery, in my opinion. That's
what I do. I'm mainly femoral access, because obviously our practice is so vascular. Yes, Dr. Vetrovic. Yeah.
Yeah, quick question, and I've never seen this addressed about the radial. What about, from a cardiac surgery standpoint, doing limas, which we emphasize? What is the damage? Has anybody ever looked at whether the patient had a pre-lima, pre-lima radial access versus femoral access, and what the risk is to the survival of that graft?
Yeah, that's a great question. I don't think that I've ever seen a paper like that.
Yeah, I don't know the answer to that.
Yeah.
It's just always worried me that we're boogering up a very good graft.
Yeah, that's very possible.
I agree. I agree. I don't know the answer to that.
Okay. Well, I guess, not a lot of radial fans on today. George, what else? I thought you had one more article.
Yes, I got one more. If I can share here one more time. And looks like it's happening.
Yep.
Yep, it just happened. Okay, so the last one I'm going to show is one that I'm going to gloss over the real hard science because I can't do that. But I think it's been well documented that South Asians have a much higher risk of cardiovascular disease, regardless of how you look at risk factors. And it seems that it's outside of what one would predict. And this is a study that was done to look at what might be a biologic reason for this. And so they showed that South Asian people with measurement of cardiometabolic disease had less vascular regenerative reparative cells, suggesting that their repair capabilities for their vasculature may contribute to this excess vascular risk in the population. So what they did was they looked at people with diabetes or cardiovascular disease that were either white European ethnicity or South Asian. And this was a UK study. And they did flow cytometry and they looked at specific enzyme activities, aldehyde dehydrogenase activity, lineage, specific marker expression, reactive oxygen species, and serum ELISA methods to do this. Anyway, at the end of the day, they showed that CD34 or whatever, primitive progenitor cells and anti-inflammatory myocytes, and there were increased reactive oxygen species, all bad things in terms of vessel repair, were significantly higher in the South Asian population. Now, the editorial comment was given by Dr. Natarajan and Dr. Patel, and he notes that, you know, there's another UK study looking that South Asians had twice the atherosclerotic risk for risk factors that wasn't explained. And these angiogenic factors or proangiogenic factors seem to be a potential issue. The question really is how much is diabetes, how much is vascular disease, and you know, they lump the two together, whether that's fair. And then the question is how do you apply drug treatment with something like bariatric surgery or other new anti cholesterol agents and so forth? Can we fix this? And but it looks like an interesting area to research. And as I said, I'm not the world's expert. This is kind of, though, I think really exciting, because in my days of cathing, I was always struck with how diffuse the atherosclerosis was in South Asians when I cathed them. It was not just one little bump here or there. It was visibly diffuse. And we all know that some of it's invisible, but this was real. And so I thought this was interesting, and maybe there'll be some comments from the vascular people who have seen far more of this, I'm sure, in other parts of the body than I have.
I think that you're absolutely right, George. Nilesh, you know, you see this, you know, and you have a fairly large South Asian community for your patients, you know, and they have really bad diffuse vascular problems.
Yeah, it's small vessel disease that we have more in South Asian. And the bigger issue, I think, the treatment won't be any medications or other stuff. I think if we have to go down, it would be aldehyde dehydrogenase or the genetic modification of whatever the difference in the gene would be. And that, I think we are 10, 15 years out if somebody works on it. Right now, I think the only thing we are doing is working on some of the atherosclerotic modifications of the genes for intimal hyperplasia, and that are rat models that we work on. So there is some the stuff, but not, I'll have to see if I can bring it up to our PhD guy who is pretty good at genetic modifications and understands it much more clearly than what we would be able to modify it. But we'll have to see which gene controls the aldehyde dehydrogenase as an enzyme, and then work on the next level of CD34 or CD14 expressions of that. But
yeah, I definitely think that there's gotta be a different kind of treatment than, you know, a traditional, you know, reducing the LDLs and antiplatelets and all that kind of stuff, and clearly it's not enough, you know. So some form of genetic modification will be necessary. Yeah.
I think this was I thought this was very exciting for a problem that I never knew what to do about.
And I think this is where, you know, American ingenuity in the industry really could make a difference. This is where I think that the future, breakthroughs are going to be. It's not going to be in meds now. I think that it's going to be in a different way. The question is, yes, if they discover something like that, how are they going to deliver it? Is it going to be an injection?
No,
Or
it's in nanoparticles that you can put in and
yeah,
inject. So it could be just an IV injection.
I
And
see.
we load those messenger RNA onto those nanoparticles and put it in there. And that's the way to deliver. So delivery is not a problem. But there is a lot of stuff. The problem we face is even if you get it, trying to go through FDA with any of these things, they have so many questions. The one graph that we are trying to get, there are multiple questions that come up, and sometimes you don't have the answers to all of this. I mean, I don't know if you come across, but the difference in the disease pattern, I work in Bronx, so we have different ethnicity, even in peripheral arterial disease, even though it's called PAD. If you see Italian, Irish, Caucasian population, their atherosclerotic disease is more of a soft erythematous plaque, where you see it in the African American or Hispanic population, it's calcification and similar to this patient, even if they are renal failure, the disease pattern is so different among different ethnicity that I don't know, we call it PAD, but it's different.
Hi, George. Yeah.
Yeah, I think you make a really great point. And the point that I would like to support is that it's been such a move now not to categorize disease, particularly as African American. And I realize there are biases that have been applied, but on the other hand, there probably are biologic differences. And I don't think we want to become so colorblind or ethnicity blind that we don't take advantage of enzymatic differences that are real and use those to treat whatever group it is. And I think it's tricky to make sure we dot all the I's and cross all the T's, but I think this makes an important point and you sort of support that.
Yeah, I think if you look at all our papers in JVS and other stuff, nowadays they say use that as a guidelines to say that we are not providing or they don't have better outcome, but understanding the disease process is probably more of a scientific way of looking at it rather than just based on that ethnic population, certain ethnic population has worse outcome, and they try to find a superficial cause for all those things. I don't think we treat people differently. It's just that the response is very different in different ethnicity.
Right.
Well, thank you very much, everyone. We're exactly on time. It's 11. So thanks. There's so many people from many different parts of the world on today, and I really thank everyone for joining us for this great sessions. Our next session is going to be in May. The April, we're supposed to have a session, but I'm actually going to be out of the country on that particular date. But we'll have a little longer session in May, and we're very, very close to finishing the agenda for May date, and I will be sending that out very, very soon. So thanks, everyone. Thank you, Dr. Vetrovec, as always, for pulling some great articles for us. A lot to think about and a great, very spirited discussion about claudication and atherectomy, which has been a part of a big news lately, and really has created some, it has really created a big impact on actual practice of medicine and approvals, etc. So this particular session is going to be placed online by our technical staff in the next couple of days, so everybody can see this session, as this was a very special session that we had created because of this. And I thank you for all the faculty, everyone who took very valuable time to do their presentations and discussion. So with that, have a great weekend. Happy Easter to everyone. And look forward to seeing you next time.
Thank you, Raj.
Thanks, Raj. Bye.
Okay.
Thanks, Raj.
Thank you.